Hi, my name is Lorraine Keller, and my research partner and friend is Teresa Ying, and we will be presenting to you our research project. But rather than start with the title of our project, we actually wanted to start with what motivated the project to begin with. So, obesity is really the motivator behind it. Obesity rates have quickly increased over the past decades. Currently, 1/3 of American adults are considered to be obese, and that is a lot of people. A lot of people that you will likely encounter in the OR. Along with the obesity rates increasing, so too have the rates of bariatric surgery. According to the American Society of Metabolic and Bariatric Surgery, roughly 150,000 to 200,000 bariatric surgeries are performed on a yearly basis. So what does this actually mean for us as anesthesia providers? Well, first of all, this patient population poses for us a very unique set of challenges perioperatively. Obesity creates a lot of physiologic changes in the body, most notably is the respiratory system. In fact, in bariatric surgery, respiratory issues were considered to be the most common complication noted. Postoperative pain management is also extremely challenging. It's actually really a fine balance between providing enough medicine to have them adequately comfortable while mitigating the risks of any kind of hemodynamic instability. So these patients are typically prone to sleep apnea and cardiopulmonary collapse when given high doses of narcotic, and this makes this balancing act a lot more difficult because our window between having them comfortable and having them have a hemodynamic collapse is much narrower. So opioids are really our mainstay for perioperative analgesia. They work well, but the only caveat is that they can make someone stop breathing if you give too much of it. So really, trying to figure out how much you can give your patient, your obese patient, how much you can give to them so that they're comfortable, but yet are still breathing adequately and not underventilating and not becoming hypoxic is not the ideal question to ask. So perhaps we should tackle this problem with a different question or a different approach. So why not ask, what non-opioid analgesic adjuvants can we give our bariatric patients so that, one, we can help them get comfortable, two, we can continue their respiratory function at an optimal state, and three, ideally decrease the amount of opioids they need to consume in order to stay comfortable. These were really the questions that started the whole project, and we wish we could say they were our own, but unfortunately they weren't. Dr. Camporisi was the one who actually had the idea for this study altogether. He's one of the Tampa General anesthesiologists, and he's extremely well read and extremely well published. So for our study, here's our working title: Systemic Intraoperative Lidocaine Infusion for the Postoperative Pain Management in Obese Patients. I'm going to go over three studies to give some literature background. And the first one is a study that is a systematic review of randomized controlled trials by McCarthy and colleagues. They actually looked at the perioperative lidocaine infusions in abdominal surgeries, cardiac surgeries, orthopedic surgeries, and tonsillectomies. They reviewed 16 articles out of the 199 that they retrieved, and here they are. And they concluded that patients undergoing abdominal surgery, the lidocaine infusions provided significant pain relief, reduced postoperative opioid consumption, decreased the opioid-induced nausea and vomiting, promoted faster return of bowel function, and they actually stayed in the hospital for a shorter amount of time. Interestingly, these benefits were not demonstrated in the patients undergoing orthopedic surgery, cardiac surgery, and tonsillectomies. The next study is a meta-analysis by Merritt and colleagues, and they went ahead and analyzed 8 randomized control trials. Here they are. And they concluded also that continuous perioperative and postoperative intravenous lidocaine infusions after abdominal surgery decrease the duration of ileus, the incidence of nausea and vomiting, the severity of pain, and the length of hospital stay. So for abdominal surgery specifically is what they looked at. And the last study I'll talk about is one that was published in the Canadian Journal of Anesthesia, hence the French that you see there. But Mignot and colleagues actually looked at 29 studies, that they displayed here over 4 pages. And they also found the same thing, intravenous lidocaine infusion as an adjuvant for general anesthesia improved postoperative analgesia in abdominal surgeries. They didn't find it in other kinds of surgeries. However, they did go on to say that they weren't able to make any recommendations because as of yet there was no study that systematically assessed the safety of the medicine and a safe dosage to be giving patients. So I'm going to show you guys our study in the PICO format. For our population, we had obese patients undergoing laparoscopic Roux-en-Y gastric bypass surgery. More specifically, here's our inclusion and our exclusion criteria. We ended up having 20 subjects because this is considered a pilot study, so we had a smaller sample size. Our intervention group received an intraoperative lidocaine infusion running at 2 milligrams per kilogram per hour of total body weight. Our comparison was an intraoperative placebo, which was dextrose running at the same infusion rate. And our outcome measurements was the visual analog scale, a safety assessment questionnaire, analgesic requirements as charted by patients or providers who gave analgesics throughout the whole hospital stay, length of stay, and then the return of bowel function. And I'm going to go ahead and turn it over to my colleague for her to finish the presentation.